Interceptive Orthodontics. Interceptive orthodontics is defined as that phase of the science and art of orthodontics employed to recognize and eliminate potential irregularities and malposition of the developing dentofacial complex. The procedures undertaken in interceptive orthodontics are serial extraction, correction of developing crossbite, control of abnormal habits, space regaining, muscle exercises, interception of skeletal malrelation, removal of soft tissue or bony barrier to enable eruption of teeth. Serial extraction. So serial extraction is a planned and sequential removal of the primary and permanent teeth to intercept and reduce dental crowding problems, which is a definition given by Tweed. The term was given by Jelgren in 1929 and it was popularized by Nance in 1940. Indications for serial extraction are arch-length tooth size discrepancy with one of the following features, that is absence of physiologic spacing, ectopically erupted teeth, mesial migration of buccal segment, and also skeletal class 1 malocclusion with a straight profile, and in patients where growth is not enough to overcome the discrepancy. The contraindications for serial extraction are space dentition, class 2 or class 3 skeletal malocclusion, anodontia or oligodontia. Anodontia is absence of teeth completely and oligodontia is partially absent teeth. Open bite or deep bite cases and mid arch length discrepancy. The rationale for serial extraction would be arch length tooth material discrepancy and physiological tooth movement. There are three main procedures which are formulated for the process of serial extraction, which are the Duell's method, Tweed's method and Nance method, and which are named after the people who have developed this method. First is Duell's method. In Duell's method, the first step is to extract the deciduous canine to create space for the alignment of the incisors. Second step is to extract deciduous first molars, and third step is to extract first premolars to permit permanent canines to erupt. This is the illustration for Duell's method, wherein you can see that first you have to extract the primary canines for the alignment of your upper anteriors, and then second you will be extracting the primary first molar, and after that you will be extracting the first premolar for the correct eruption and alignment of the permanent canine. Next is the Tweed's method. In Tweed's method, we will be extracting the deciduous first molars followed by extraction of first premolars and then deciduous canine. And Nance method is the same. Crossbite. Crossbite is an abnormal relationship of one or more teeth to one or more teeth of the opposing arch in the buccolingual as well as labiolingual direction. This is the crossbite. Now, classification of crossbite. Crossbite can be classified into anterior or posterior crossbite, buccal or lingual crossbite, dental, skeletal or functional crossbite in terms of etiology. Scissor bite. So scissor bite is a situation in which the posterior teeth overlap vertically in habitual occlusion with the antagonist without contact of their occlusal surfaces. The deviation of the affected teeth from their ideal positions could occur either in a buccal or a lingual direction. So, and you have dental crossbite as well as skeletal crossbite. Dental crossbite is an abnormal relationship between antagonist teeth that is due to deviations in the position or inclination of one or few teeth. The relationship between the maxilla and mandible will be harmonious. So such crossbites can be treated by tooth movement alone. This is a dental crossbite. This is a single tooth crossbite and crossbite involving more than one tooth. Now this is skeletal crossbite, the anterior posterior crossbite that is due to a sagittal or transverse in coordination in the size or shape of the maxilla or mandible. The treatment usually requires a skeletal expansion by means of rapid maxillary expansion or orthognathic surgery. A skeletal crossbite where you can see that there is a complete anterior crossbite. This is scissor bite. Now functional crossbite is pseudo crossbite. So a crossbite that is due to a shift of mandible into a faulty habitual occlusion because of premature occlusal interference, and this shift may occur in an anterior as well as lateral direction. So this is a pseudo crossbite. Pseudo crossbite occurs when there is an occlusal interference and patient knowingly bites in an anterior position so as not to interfere with the occlusal interference, and they'll be biting in a more comfortable position to bypass the occlusal interference, and hence developing into a habitual or functional crossbite, which on prolonged duration can develop into a permanent or true anterior crossbite. Now, correction of crossbite. The crossbite correction can be done by a few methods. One is tongue blade therapy, wherein you are using a tongue blade to apply a force continuously over the period on the lingual aspect of the upper anterior, so that the developing or the erupting upper anteriors erupt in a more anterior position. Now, inclined plates or composite inclines, then Hawley's appliance with set spring, and quad helix. Quad helix is an expansion appliance, so aids in expansion of the upper arch and hence relieve the crossbite. This is an inclined plane or a Catalan's appliance as we call it. It's called an inclined plane because the area where the teeth comes in contact, the plane is inclined at an angle of 45 degree, and thus when the upper incisors comes in contact with this appliance, they'll be guided more anteriorly and they'll erupt in a anterior position to relieve the anterior crossbite. So, but this can be given only in a patient with a developing crossbite, that is when the upper anteriors are erupting. Now, coming to interception of habits, we have seen a lot of deleterious habits like thumb sucking, tongue thrusting, mouth breathing, etc. So these has to be identified at the earliest and if possible have to be intercepted by giving habit breaking appliances. So habit in the orthodontic sense refer to certain actions involving the teeth and other oral or perioral structures which are repeated often enough by some patients to have profound and deleterious effect on position of teeth and occlusion. The habits that can affect the oral structures are thumb sucking, tongue thrusting, mouth breathing, etc. Thumb sucking, this habit, if present up to 2.5 to 3 years, is considered quite normal. But if it exists or persists beyond 3.5 to 4 years of age, it can have a damaging influence on the dentoalveolar structure. It can cause proclination of the upper anteriors, protrusion of the maxillary arch, and also anterior open bite. Tongue thrusting is defined as a condition in which the tongue makes contact with any teeth anterior to the molar during swallowing. That happens when there is a persistent infantile swallowing, and it is present with open bite and anterior proclination, intercepted by using a habit breaker like a tongue thrust or a tongue rake, and a patient has to be trained and educated on the correct technique of swallowing as well. Now coming to mouth breathing can be obstructive as well as habitual in nature. So nasal obstructive breathing such as can happen due to nasal polyps, nasal tumors, chronic nasal inflammatory conditions, and deviated nasal septum. The persistence of habitual oral breathing is an indication to use a vestibular screen to intercept the habit. Now we have got certain muscle exercises to increase the tonicity of the muscles. Exercise for masseter muscle, exercise for circumoral muscle, exercise for the tongue. Exercise for the masseter muscle is to strengthen the masseter muscle, clenching of teeth by the patient while counting to 10, and repeat the exercise for some duration of time. Exercise for pterygoid muscle. This exercise is as advised in case of distal occlusion, that is in skeletal class 2 patients. They are asked to protrude the mandible as much as he can and then retract. This exercise should be repeated till the person is tired, and developing this habit helps in keeping the mandible in its correct position. Exercise for the lip or circumoral muscles. Upper lip is stretched in the postero-inferior direction by overlapping the lower lip. Such muscular lip activity allows the hypertonic lips to form oral seal labially. And hypertonic lips can also be exercised by holding a piece of paper between the lips. Parent can stretch the lips of the child in the postero-inferior direction at regular interval. Then swashing of water between the lips until they get tired. Massaging of the lips. Use of an oral screen with a holder to exercise the lips. Button pull exercise and tug of war exercise. So in this picture you can see that it's a myofunctional speech therapy exercise. Button and it consists of a button and a string. So what happens is you ask the patient to hold this button in front of the teeth but behind the lips, and close the mouth and ask the patient to tug or hold on to the thread and ask them to pull it. So the patient shouldn't allow the button to fall down, they should be able to hold the button back with their lips, and this in turn acts as a lip exercise and can increase the lip strength and tonicity. Now this is also a lip exercise wherein the patient is asked to pull the lip in a posterior inferior direction and asked to repeat for a few times so that this can increase the lip seal manually. Exercise for the tongue. There are 4 exercises which are proposed. 1 elastic swallow, 2 elastic swallow, tongue hold exercise and hold pull exercise. 1 elastic swallow, the first picture you can see that the patient is asked to hold the intraoral elastis on the anterior 1/3 of the tongue and ask them to swallow. But the patient is instructed so as not to swallow or move the elastic from the prescribed position, and thus the tongue will be holding the elastic in its position on the palate, whereas it can increase the tonicity and strength of the tongue muscle. And in the second picture you can see the 2 elastic swallow. The 2 intraoral elastics are placed in the anterior 1/3 of the tongue and asked to swallow. Then you have the tongue holding exercise, that is, ask the patient to hold the tongue outside the mouth for some period of time and repeat it after some time, and this will also enable the to increase the tonicity of the tongue. And you have hold pull exercise, that is, ask the patient to hold the tongue upward touching the palate for a period of time and relax and then repeat it after some time. This can increase the tonicity of the tongue. Now next is space regaining. For space regaining is something which we do when you lose a deciduous molar. There is early loss of a deciduous molar or a teeth, and if there is a mesial migration of the adjacent teeth into that area, there will be a space loss. So this space has to be regained for the eruption of the permanent teeth. For that we use certain appliances. So we have got fixed as well as removable appliances. Fixed appliances are Herb space regainer, jack screw space regainer and Gerber space regainer. Removable appliances include Hawley's appliance with helical spring, Hawley's with split acrylic dumbbell spring, Hawley's with slingshot elastics, Hawley's with palatal spring, Hawley's with expansion screws. Now coming to interception of skeletal malrelation, interception of class 2 malocclusion. Skeletally, if there is a maxillary excess, you can use a face bow with a headgear. And in case of mandibular deficiency, you can go for myofunctional appliances like twin block, Frankel, activator, etc. Coming to interception of class 3 malocclusion, if there is a maxillary deficiency, a face mask therapy or a Frankel 3 appliance can be given. In case of mandibular excess, a chin cup therapy with headgear is advised. Removal of soft tissue and bony barriers. The soft tissue and bony barriers can hinder the eruption of the permanent teeth into the oral cavity. So such tissues should be removed at the earliest. And also supernumerary teeth, if present, should be removed at the earlier time, because it may hinder the eruption of the permanent teeth and also can deviate the path of eruption of the permanent teeth into an ectopic position. And also the fibrous bony obstruction of the erupting tooth bud should be removed. Thank you.